Greetings. My name is Bill Moss, and I'm the Executive Director of the International Vaccine Access Center. And it's my great pleasure to welcome you to this webinar that to address some of the very important issues of the strategic priority number 5 of the Immunization Agenda 2030 on outbreaks and emergencies. The title of our webinar today is Addressing Challenges in Vaccination in Fragile Contexts. What are the perspectives under IA 2030? We have 8 speakers lined up for the next hour and a half, and we'll need to move quickly through the content. The webinar is divided into 2 parts. The first part is Reaching Children in Fragile Contexts, and we'll hear from Dr. Kate O'Brien, Director of Immunization, Vaccines, and Biologicals at the World Health Organization. Dr. Natasha Crocroft, who's the Senior Technical Advisor for Measles and Rubella Immunization at IVB at the World Health Organization. Agidi Sumek, who will be talking to us about reaching children in conflict-affected Central African Republic from IFRC, the International Federation of Red Cross and Red Crescent Societies at the country office in the Central African Republic. And we'll conclude the first section with Dr. Yasser Najib, who's Senior Medical Officer for the Syrian Immunization Group, speaking about support for routine immunization in northern Syria. We'll have a few minutes for discussion, and then we'll move into the second half of the webinar on strategies for COVID-19 vaccination in fragile contexts. And we'll hear an update on national vaccine deployment plans to reach populations in fragile and conflict settings from Dr. Elba Pasha and Alejandro Costa from the World Health Organization. We'll then hear from Dr. Ghulam Nazari, Reaching Underserved Communities in Afghanistan, who's Director of the Afghanistan National EPI Program, and Dr. Amna Kahari from Sudan, who will discuss challenges with COVID-19 vaccine hesitancy in Sudan. And then Dr. Robin Nandy, the Chief of Immunization at UNICEF, will provide a discussion and wrap up. So we have a very tight schedule over the next hour and a half. I will serve as the moderator and will do my best to keep speakers on time. We need to keep to this very tight schedule. And we're going to start off with Dr. Kate O'Brien, who will give us an overview of the importance of this strategic priority 5 in the Immunization 2030 agenda. Kate, over to you.
Thanks so much, Bill, and I'm so delighted to be in this session and with all of you. According to OCHA's Global Humanitarian Overview, there are currently 236 million people in need of humanitarian assistance in about 56 countries. This is the highest figure registered in decades. The number of wars and the duration of wars have been increasing over the years, from 16 such wars in 1991 to 41 in 2019. And children are one of the largest groups affected by these conflicts. In 2018, it's estimated that there were 415 million children. That's 1 in 6 children of the whole world who are living in or in proximity to a conflict zone. Populations who live in fragile and conflict-affected and vulnerable settings are at increased risk of morbidity and mortality from communicable diseases, and especially from vaccine preventable diseases. And that's because of several factors: poor access to safe water and sanitation, inappropriate shelter, poor nutrition, and limited access to healthcare and routine health services. And low vaccination coverage is a constant in these settings. In 2019, overall in the world, nearly 20 million infants did not complete their vaccination schedule, and 14 million of them were the so-called zero-dose children, those who get no vaccines through the routine immunization program. Of those, about 40% reside in areas affected by fragility and conflict, and a large proportion of them are harboring in some few countries, including Nigeria, DR Congo, Pakistan, and Ethiopia. So the failure in the delivery of immunization services in fragile and conflict settings has led to an increase in vaccine preventable disease outbreaks, and those have high morbidity and mortality consequences. They include the diphtheria outbreak in 2017 among Rohingya refugees from Myanmar living in Cox's Bazar in Bangladesh, as well as at Yemen, a diphtheria outbreak also in 2017 with over 3,000 cases and 203 associated deaths. And both polio, the CVDPVs, and measles outbreaks have also been reported in Syria in 2017, and Ukraine, we know, fueled in part the measles outbreak in Europe in 2018 that resulted in over 80,000 cases. The main factors affecting delivery of immunization services in fragile and conflict settings are insecurity, loss of healthcare workforce, mistrust and disinformation, and population migration, as well as attacks on health facilities. So this worrying situation calls for a concerted effort to address the challenges for improving equity in immunization and really using new approaches and technologies, understanding better how fragile environments, insecurity and conflict act as drivers of low vaccination uptake and inequitable service provision. These are critical for achieving the goals of IA 2030 and Gavi 5.0. So the progress towards the global goals related to vaccination coverage and morbidity and mortality reduction are going to require special attention and focus on fragile settings. To improve equity in immunization coverage, there is an urgent need to identify initiatives, service delivery strategies, innovations, and new partnerships beyond the global health sector that will secure access to vaccinations and essential health services in fragile and conflict areas and contribute to this overall reduction in the number of zero-dose children worldwide. To operationalize these approaches and ensure technical alignment and sound partnership in the areas of emergencies and outbreaks in support of IA 2030, the Strategic Priority 5 working group will serve as a platform for discussions across partners working at that operational level in fragile, conflict, and vulnerable settings. This SP5 working group feeds into other structures of IA 2030 governance, including the IA 2030 Partnership Council, and the working group on Strategic Priority 5 is co-led by IFRC and UNICEF, and I'm very grateful for that, and convenes a diverse cross-section of immunization partners. So the key focus areas for this fifth strategic priority, the outbreak and emergency priority area, is first to contribute to normative strategies, processes, and recommendations for global, regional, and national levels to reach communities and zero-dose children in these fragile and conflict-affected areas with immunization services. Second is to facilitate the operationalization of IA 2030 and Gavi 5.0 and translate the Equity Reference Group recommendations for reaching zero-dose children and missed communities into fragile and vulnerable areas. The third is to document the impact of conflict on the delivery of immunization services in selected countries and share experiences and best practices from implementation of these innovative strategies and approaches to providing immunization in fragile and conflict areas. And fourth is to contribute to the analysis of and solutions to other barriers and facilitators to appropriate decision-making on implementing vaccine strategies in humanitarian responses with an emphasis on political economy, technical expertise, capacity of humanitarian health actors, and effectiveness of coordination. And fifth and finally is to provide innovative solutions and partnerships that can really enhance the effort and investments aimed at increasing access to immunizations and primary health care services in these fragile and conflict settings and contribute in that way to an overall reduction in zero-dose children. So this session today is structured along two themes. First theme is reaching children in fragile contexts, in which we'll cover the impact of COVID-19 and the risk of measles resurgence, as well as reaching children in conflict-affected Central African Republic. And the second theme is strategies for COVID-19 in fragile contexts, during which we'll look at updating the national vaccine deployment plans to reach FCV populations and reaching underserved communities in Afghanistan and challenges with COVID vaccine hesitancy in Sudan. I'm sorry, I'm not, because of scheduling conflicts, I'm not able to stay for the whole of the presentations and discussion, but I really want to end by thanking the IFRC for hosting this session, for IVAC for coordinating this, and I look forward to hearing the readout. And thank you so much to UNICEF and IFRC and all of you participating in this work theme, which is so essential to achieving the goals of IA 2030 and Gavi 5.0. Thank you so much.
Kate, thank you very much for highlighting the critical importance of reaching children in fragile contexts and the tasks ahead for the working group and really for all of us in addressing these vulnerable populations. So we're going to turn next to Dr. Natasha Crowcroft, who's the Senior Technical Advisor for Measles and Rubella at WHO. Natasha?
Thank you very much, Bill. Thank you to Kate for that amazing introduction. I'm going to talk about really focus on measles, and I think I've got a few key messages I'm going to say first before I dive into this slide. We are starting in a bad place, and before this pandemic even hit. We're now in a worse place because of the pandemic. And we do need to take action to get us out of this place, but we also need to think to the future. And I think some of the things Kate said will resonate with what I have to say in that to get us to a better future, we need to have some innovation and some change in strategy. So if I could have the first slide, please. Just to start off, why I'm here, why are we talking about measles in particular, because this webinar is about much broader set of topics, but the reason measles is in here is because, as a reminder, it's described as a tracer of the strengths of immunization systems. Why measles? It requires the highest coverage of any vaccine preventable disease, and that means that when you have an issue with coverage, measles comes back first, it comes back faster, it comes back and it hits communities harder. It has the highest case fatality rate. And so it really is a marker of when things have gone wrong, and it's a very early marker, and it's particularly hazardous, has the highest case fatality in these fragile and conflict-affected areas, in refugees and people who are suffering from malnutrition and poverty and vitamin A deficiency. So it stands out amongst the vaccine preventable diseases. And the other side of that is that the vaccine has the greatest benefits. It brings the largest number of lives saved. It's a very cheap, effective vaccine, so the return on investment is tremendous. And this figure here shows you how, if you look at all the vaccines that we've been delivering through routine immunization during COVID-19, measles vaccine actually stands out as having the greatest benefit ratio compared to which is in red. And if you look at all the other colors, all the other vaccines we're delivering in routine immunization programs in this analysis from the African region. Next slide, please. I said we'd started in a bad place, and here's the coverage data that we have from before the pandemic. And this is the latest we have in the routine WUNIC data. This is presented the other way up to what you might be used to, in that I've graphed it as the proportion of children who have not been vaccinated. So it's upside down to what you might usually expect to see. And the key message is really that if you look at the red bar, that's the target for measles. That's where we want to be, is with the proportion of children who are unvaccinated below that bar. And really, none of the regions have consistently been able to get below that bar. And for most regions, the pattern has been either flat, or even the proportion of children who are unvaccinated has been increasing over the past 5 years. Only a very few, the European region dipped under in the 2019 data. Southeast Asia was heading in a good direction, but hadn't got there yet. But the other regions are really either stuck or indeed worsening situations. So in terms of our routine immunization and the receipt of the first dose of measles vaccine, progress before the pandemic in the last 5 years, and in fact, in the last decade, was flat. It had really stalled. So all the strategies we've been using to try and make progress were not getting us where we needed to be. And so something really needs to change. Next slide, please. So on top of that situation, we had the pandemic. And of course, that wasn't good for routine immunization. And here you see how very early in the pandemic, routine immunization plummeted, the coverage plummeted in most regions, but not all. So that early fall in coverage was then replaced by a very pleasing recovery. What we don't know right now is whether or not the children who were missed out in their routine doses in that early part of the pandemic, whether they had a chance to be caught up. And the World Health Organization released catch-up guidance during this time period to encourage countries to catch up the children that have missed out. But we won't know for some time whether those children were actually reached. Next slide, please. The other piece of reaching children with immunization is via campaigns. What you see here in the figure is all the campaigns that have been disrupted over the time period up to this month. And the red line are measles campaigns. And you can see that the recovery of measles campaigns has been much slower than all the other antigens. Currently, we have 23 measles campaigns that are disrupted or delayed due to the COVID-19 vaccine. Next slide, please. And what that represents is millions of children at risk. Sorry, if you could go back. Millions of children are at risk. The latest estimate, if you could just go back one slide, is that 140 people are affected by these delays to campaigns. So that's a tremendous risk of outbreaks, both through disruption to routine and to disruption due to disruption to campaigns. And these campaigns are happening in countries that are already at the highest risk of outbreaks, which is why the risk is so high. Next slide, please. During 2020 was a strange year in that we really didn't have a huge number of cases of measles reported globally. There were several reasons for that. Firstly, in 2019, we had the highest rate of measles worldwide since 1996. So it was a terrible year for measles outbreaks. And that leaves behind it a lot of people who are immune. So it wasn't that surprising to have fewer cases in 2020, but really cases plummeted. And other reasons for that, apart from the fact there had been this big spread of measles in the year before, was that the labs that do the testing had switched over to doing COVID testing. So they weren't testing for measles. People weren't coming forward to be tested in the first place, and surveillance was really not functioning because the whole public health system was switching over to the COVID response. So not surprisingly, we have very patchy data for 2020, but what we do know is that outbreaks carried on. And here we have outbreaks, and these are defined as countries that had more than 20 cases per million population, which is our current definition of large and disruptive outbreaks. You can see they're very focused in the African region, but they also affected other regions. And you will recognize that many of these countries affected by outbreaks in 2020 are also fragile and conflict affected states. Next slide, please. So what are we doing about this? So right now, the strategy is the Measles Outbreak Strategic Response Plan, which WHO has launched. And this plan includes a vision where all countries are equipped with robust measles outbreak preparedness, prevention, and response systems. So it's about coordination and preparedness for outbreaks, rapid response to outbreaks, but also about prevention. It includes prevention of outbreaks, which is absolutely critical. And the goal is to help countries, to support countries to do this. WHO working with partners. In this plan, originally, we identified 45 measles high-risk countries. During this time, since we launched this, another 3 countries have been added to that list just to illustrate. But this is a moving target. It's a flexible plan in which we're trying to address the needs of countries, and those needs are changing, evolving, and unfortunately, the numbers of countries at risk are increasing. 17 of the 48 countries currently that we're looking at for this plan are also World Bank's fragile and conflict affected countries. And when you look at those countries, the more intensity, and the more fragile they are, the more likely they are to be also at high risk for measles outbreaks. So 4 out of the 4 high intensity conflict countries are also in our list of countries we're very concerned about in terms of measles outbreaks. And 9 out of the 13 medium intensity conflict countries. So, so it really is, there's very strong overlap between the issues we're talking about in terms of conflict in fragile countries and the issue of measles. Next slide, please. So when we launched this plan, we also conducted a costing exercise, which was very important because we knew we didn't have the funds to implement what we needed to do to prevent these outbreaks. So jointly with UNICEF and with polio, uniquely, this hasn't happened before, the measles folk went out asking for funding in the autumn of 2021. We have an estimate of a 3-year gap of $255 million needed to fill the gap in resources, to add to the resources we already have in order to strengthen countries in their prevention and their coordination and preparedness and response to outbreaks. And this, since we launched this call to action, the need has just increased and increased and become increasingly urgent. Next slide, please. So to draw some conclusions, this is my last slide. I'm borrowing the title of a paper that was published by the chairs of the regional verification committees just this year in Nature. A dangerous measles future looms beyond COVID-19. We see immunity gaps widening in fragile and conflict-affected countries because of delayed campaigns and disruption to routine immunization and complete lack of capacity to build routine immunization. We see the increasing risk of measles outbreaks going into the rest of 2021 and into 2022. So we need urgent action now to prevent, prepare, respond to and recover from measles outbreaks that we know are coming or have already started. This requires political will to support action now and funding, as I've said. But the other thing, I wanted to end on a positive, future-focused note about innovation. Kate mentioned this as well. Where we are now is a result of everything we've tried to do in the past. If we want a different future, if we want things to look different in the future, we need to do things differently in the future. And that's not just about changing strategy, but also about changing the tools we have. Rapid diagnostic testing is a way we could be putting surveillance into places where there are no laboratories. Microarray patch vaccines, which is what's in this image right that's on this slide, are ways in which we can reach people in remote communities or during peace days in conflict areas much more quickly than with vaccines that require needles. These kinds of technologies require funding, which requires will to drive them forward. They require that acknowledgement and recognition that we need these new tools. They may be more expensive than what we have already, but what we have already isn't reaching anybody in these conflict areas. So we need something new. The comparison is nothing. The comparison isn't the existing tools. So this is something I think looking to the future, we have the potential to change things, and we need to grasp that opportunity with both hands. So thank you very much, everyone. My next slide, I think, is just an acknowledgement of the team and everyone I work with. And thank you for listening.
Natasha, thank you very much for that excellent summary of the global measles situation, and particularly the importance of measles in fragile and conflict setting, and the sense that maybe this is the quiet before the storm. I hope not, but we are in a very precarious situation right now, and your call for urgent action is very important. So thank you very much, Natasha.
Thank you.
We're going to move on to hear more voices from the field, and our next speaker is Dr. Egidis Sumak, the immunization team lead for IFRC in the Central African Republic. And the title of his talk is Reaching Children in Conflict-Affected Central African Republic. Dr. Sumak.
Merci. Bonjour à tous.
Thank you very much. Hello, everyone. I'm going to speak in French. So I believe that you have a translator. Right.
Yes.
Our subject here is about data-driven systems of community engagement to support API in conflict settings. So, you know, Central African Republic is a country where there's a certain recurrence of conflict, and the objective of this presentation is to try and see how, through our work, every village, every camp where people or children live should be visited by vaccination teams so that the children are vaccinated. So we are trying to ensure that all the newborn and pregnant mothers are registered in a list, the register for vaccination every month. So it's also to ensure that all children that may not have been captured are recorded and also gotten back to routine vaccination. Next slide, please. Next slide, please. So we have focused on community engagement to reach each child in the regions number 4, 5, and 6 in Central African Republic, regardless of where these children are. In our slogan, when we really want to push the volunteers to go as far as they can, we tell them, even if the child is underwater, the volunteer must reach them and vaccinate them. So you have a picture here on the slide of a volunteer who is vaccinating a child and the children of nomads in the district of Bamini Bangora, and that is situated about 80 kilometers outside that area. So this region 4, 5, and 6 is a region that have about 5,000 villages, and it's very big. It's almost half the surface area of the country. I'm just saying that it's you can compare that to the size of Germany. So the area where we're working is almost half the surface area of the country. In terms of micro planning, we have tried to undertake community participation, working with the leaders of different communities, as well as creating, after this micro planning, a certain list, actually a database of all the communities and settlements in which we are working. Our system is such that every community has community volunteers or a community volunteer. Every village has a volunteer or several volunteers, and their role is to ensure that all the strategies in as far as vaccination is concerned are well organized, and that we have activities monthly, and that all the children are traced. Those that are not on the list are found, and therefore a certain plan for vaccination is created so that they're able to catch up. So we have these volunteers they're located at health facilities, and they're actually in charge of ensuring that there's the updating of the vaccination register in these health facilities, because we need a list of these targeted children and pregnant women. This list must be updated regularly, especially on a monthly basis. So they have the role of identifying these children that may not have been captured on this register, so that the children can be able to be traced, found, and actually vaccinated. Next slide, please. What do we do to reach each child, every child? So what do our community volunteers do? Their work is to ensure that all the children that are targeted in the villages and in the displacement areas and mining areas, fishing areas, are able to be involved in the vaccination sessions that have been organized around their area. So those that may not be registered or are traced, identified, and assisted to catch up in as far as vaccination is concerned. In terms of these health facilities, as I said earlier, the role of the facility volunteer is very crucial, because they contribute to the updating of the list of the vaccination list. You know, we are in a country which has this recurrent conflict, and for more than 20 years, we've not had a census, a population census. So the data that we're using is actually administrative data that is a bit out of date. So we have we try to actually therefore update these numbers, and I think updating is important, and we do this regularly through our volunteers. This is what is helping us to avail at the health facilities an updated list of targeted children and pregnant women that need vaccination. As you can see on the slide, you have our volunteers during a vaccination campaign when they were responding to the last outbreak of polio, the world polio, in a district that is next to, they're moving in the villages just to find these children and identify them. Next slide, please. Next slide, please. So here we have this health facility of complete or integrated management, and our approach is such that our volunteers, the first level, first line, those ones in the village, are supervised by those volunteers, those ones that are faced at the health facility. So the volunteers based at the health facility are the ones that supervise the volunteers in the village. So we have 10 to 15 volunteers per supervisor. And then in terms of the district, which is the second line, these volunteers are coordinated by the focal points. These are from the Red Cross from the Central African Republic. So these ones are at the district level, and these focal points are supervised between 30 and 40 supervisors in their areas of work. So here you can see a picture of a focal point, the one in red, who is supervising those supervisors who are based at the health facility. Next slide, please.
Nous organisons mensuellement.
So we organize monthly meetings for monitoring, data monitoring at the district level. And here you can see the form, the reporting form for the volunteers from these health facilities. So these meetings are done in the presence of the leader, the community volunteer leader, and their supervisor, because as you can see, we are required to also be accountable to the community, so that then they also be able to be involved in as far as vaccination is concerned. So these reports are submitted by the community volunteers, cover 5 domains. First and foremost, the outreach sessions done, because this is the micro plan, and therefore these volunteers need to verify regularly if the sessions, the outreach sessions for vaccination have been undertaken, yes or no. They should also be able to update the list of newborns as well as pregnant women. They should also be able to report the number of children that have been lost, that have been found and updated monthly. They should also have a report on the sessions on vaccination for those that have been organized. They should also be able to come up with a report on the surveillance at the community level.
Dr. Sumak,
looking at the defaulters.
Dr. Sumek, I'm sorry to interrupt, but we will need to wrap up soon. We're running a little over time. We're running a little over time. Thank you.
Ok, merci. Je vais finir très rapidement. Les données sont transmises par téléphone mobile par les...
Thank you very much. I'm just going to summarize quickly then. So the data are sent by mobile applications to the focal points, by focal points at the national level. And here, this allows us to understand the performance of the volunteers. Next slide, please. Next slide. I'll continue here. Next slide, that slide, that's okay. So here on this one, you have a database, and that database talks about the health facilities that are functional and those that are not functional. So these are activities of the volunteers and so on. And then here on this new slide, you have some results achieved so far in the conflict setting. So we've been able to increase the number of health facilities vaccinating by 100%. We've also been able to increase the number of children vaccinated by 30%. And in terms of identifying and catch up of unvaccinated target children in the remote areas, this has been done. And we have the antigen 23, which is the Penta 3. So you have this slide here that shows all those details, and this is back to 2018, and you can see the second bit that shows the activities of the response against the polio virus outbreak of type 2 that through which we mobilized a lot of people. We have as well an increment in terms of the rate of detection of paralysis. This is something we also set out to do since the beginning of the project. Next slide, please.
Slide suivant, s'il vous plaît.
The next slide, please. So our success is based on the fact that the population believes and trusts in the Red Cross volunteers that work with them. And we are neutral, and we do have a certain access by our volunteers. We organize meetings of acceptance even with the armed groups and all the community leaders. So this has really helped us work all over in this conflict zone. So next slide, please. Next slide. So some challenges and constraints. We have insufficient human resources. We don't have a policy and clear directives that requires that all health establishments can undertake vaccination. So that is a constraint. I also spoke about outbreaks, especially of measles and polio. And this obviously occupy the time of almost all our staff, and of course insecurity. Next slide. Next slide. All right, to finish, we have established a system of community engagement with over 3,000 community volunteers. And we've also come up with several innovations regarding the systems for data-driven systems for community engagement. And our system is based on the use of volunteers who have been accepted at health facilities and the community level. And they work with the leadership of those health facilities. We also come up with vaccination strategies and campaigns, and we've also increased the number of facilities that are vaccinating. And we have more than 15 of such facilities that we have involved additionally. And then we've also been able to obtain significant results that are very encouraging, especially in the conflict settings. We've also been able to increase the way in which the results are realized in as far as this aspect of vaccination is done, especially in these insecurity settings. Thank you very much.
Thank you very much, Dr. Sumek, and it's really important to hear your experience in using community volunteers to promote childhood vaccination in this challenging setting. We've fallen a little bit behind. Our next speaker is Dr. Yasser Najib, who is a senior medical officer for the Syrian Immunization Group, is going to talk to us about support for routine immunization in northern Syria. I'm going to ask that speakers really try to keep to their allotted 10 minutes because we are falling behind. We're going to have to lose our discussion section as a consequence. Dr. Najib.
Thank you, dear. Dear all, good afternoon. I'm Dr. Yasser Najib, a senior medical officer in Syria Immunization Group that operates in northwest Syria in the vaccination field. Thanks all of you and thank WHO and other partners for giving this opportunity to present on the situation of routine immunization in northwest Syria. I know time is very limited and there is a bush of information, but I will do my best to adhere to the time frame. I will try to explain how partners are working together in vaccination field in northwest of Syria. Next, please. In northwest Syria, more than 4.3 million live. The crisis in Syria started 2011 and the health system collapsed in North Syria, the opposition-controlled area. In northwest Syria, there is no Ministry of Health and the health services are offered by NGOs and INGOs. SIG was formed in late 2013 as a response to the polio outbreak in North Syria. SIG is tasked to lead and coordinate immunization activities in northern Syria through strategic planning, capacity building, restoring EBI, implementing campaigns. For example, SIG implement 25 house-to-house OPV campaigns, 3 MR campaigns, and others campaigns. Also, SIG work on coordinating with stakeholders and also vaccination financing. Next, please. Syria Immunization Group consists of 2 bodies, General Assembly, NGOs and INGOs providing medical aid in north of Syria and involved in routine vaccination activities. It is co-chaired by WHO and UNICEF. The second body is Technical Committee under the lead of WHO and UNICEF also. There is a signed statement of principles that regulates the relation between stakeholders. It clarifies the tasks, the responsibilities of the different parties. Regular SIG General Assembly meetings are conducted to approve strategic issues, review reports, and performance. Next, please. This is the organogram of Syria Immunization Group. SIG coordinate inside Syria with Health Directorate in the opposition area. SIG co-lead by WHO and UNICEF and supported by WHO and UNICEF. As I mentioned, it consists of technical committee, that means Syrian doctors and other staff in Turkey and inside Syria. In addition to General Assembly, which consists of NGOs and INGOs as explained. Next, please. Here, SIG, how the work is ongoing. Expanded program on immunization has 93 vaccination centers. It is managed by NGOs and SIG Technical Committee. NGOs are responsible for administrative and financial issues, while SIG Technical Committee is responsible for technical issues through all levels, central, governorate, and district levels. Financially, WHO support 40 out of the 93 centers, of course, support the operational cost, and other 53 centers are supported by other donors. All this through NGOs and INGOs. SIG Technical Committee in central, governorate, and district levels coordinate and collaborate with NGOs, INGOs for successful and smoothly work on the program. Next, please. Here is the map of northwest of Syria with the distribution of vaccination centers. The yellow and green ones, while the blue ones are the cold warehouses. The program started in March 2017 with 5 centers only, and gradually the number of launched centers increased to cover the entire geographical area. Next, please. Social mobilization in the program. Each vaccination team has social mobilizer, works on raising awareness among parents and follow the defaulter children. In addition, 55 sub-district social mobilizers work systematically on active search for zero-dose children. This strategy started 2019. At the beginning, the percentage of zero-dose children was 10% and is decreased gradually. And in April 2021, this percentage reached only 2.2. Next, please. Reporting and supervision. SIG used DHIS2 to collect, aggregate, analyze data, and submit the regular reports on all levels. Supervision is conducted on regular basis from 3 levels: central, governorate, and district level, with the needed feedback. Next, please. This is only one indicator, progress of Penta-3 coverage by years. Starting from 2017, the percentage of coverage of Penta-3 was only 16. It's worth to mention that the percentage in 2020 decreased instead of increasing due to more than one reason, as it will be explained in the next slide. But look for the April 2021 till April, the coverage of Penta-3 increased to 73. Next, please. The main challenges, the main 3 challenges: security situation, population movement, and COVID pandemic. Regarding the security situation, due to evolving security situation in 2020, 10 vaccination centers were closed and 23 vaccination centers were relocated in more safe location to serve the displaced population. Also, due to the military action in 2020, there was a huge population movement. More than 1 million people left their homes and transferred to more safe area in the north, near to the border with Turkey. This forced us in SIG to rebuild the network of vaccination centers, micro plans, and redistribute the targets. Of course, this accompanied with decrease in coverage and increase in dropout rate for several months. Third evolving challenge is COVID pandemic. With the beginning of the pandemic, all 622 vaccination service providers were trained on infection prevention and control. All IPC requirements were offered in vaccination centers. The impact of the pandemic on the vaccination program was evident through the low demand for fear of infection. Also, 5% of planned sessions were cancelled for adaptation to the pandemic. House-to-house OPV campaign was postponed from April 2020 to October 2020 due to the COVID impact. Next, please. Here a brief about the ongoing COVID vaccination campaign. SIG had the responsibility for COVID-19 vaccination deployment with support of WHO and UNICEF. 53,800 AstraZeneca vaccine doses were received on 21st of April, targeted group health and community workers, 93 vaccination teams were assigned and trained. Campaign was launched on the 1st of May, 2021. There were clear hesitancy accompanying the campaign, but the situation is improving day by day. 8,908 beneficiaries were vaccinated till 19th of May. Over.
Dr. Najib, we'll have to wrap up. We'll have
Thank
to.
you. Thank you.
Oh, great. Perfect. Thank you very much. And that was an excellent summary of the challenges being faced in northern Syria and the really important work that SIG is doing. We've fallen about 6 minutes behind our schedule. Not terrible, but we need to try to make up some time in order to have any discussion. I'll ask any of the speakers if you could look, or the speakers to look into the Q&A, and if you can address any of the really interesting and important questions that are coming in there. We're going to move right now to the second half of or the second section of our webinar. We're moving from reaching children in fragile context to strategies for COVID-19 in fragile context. Hopefully we'll have a few minutes for discussion at the end, but I'm going to turn it over to Dr. Eva Pasha, who's going to talk to us on an update on national vaccine deployment plans to reach FCV populations.
Hi, good morning, good evening, everyone. Next slide, please. Let's launch straight into it. So just a quick update, which Kate actually alluded to before. Just looking at humanitarian settings, the Global Humanitarian Overview is essentially an international appeal, interagency appeal across countries for the most vulnerable and at-risk countries globally. So there are 56 countries that are targeted within that. And as Kate said before, the international community, which includes the UN, governments as well as NGOs, have identified 236 million people at need. So just for this analysis, I'm just going to focus on 30 countries which have international appeal, which cover about 210 million of these most vulnerable. So we're really looking at what could possibly be the most vulnerable people at risk, as we're seeing. Okay, so if we just have a look at the graph on the right, we see it's great. You know, it seems to be quite good that most countries have actually started their vaccination campaigns. However, we are seeing that disruptions are occurring, whether it's due to supply delays and challenges for COVID-19 vaccinations, such as is seen in Bangladesh, or political turmoil and escalating conflict. So what we're seeing in Myanmar and OPT. We do have some good news. This is orange here, but CAR has actually started their vaccination campaigns, but the other countries that are highlighted below, which haven't started, it's either due to logistic issues that they're facing, or indeed the political situations that are constraining vaccination rollout. So next slide, please. I just want to highlight a position paper that was developed with 28 humanitarian organizations, UN organizations, NGOs, UNICEF, WHO, IFRC, most people, just really what we should be looking at for COVID-19, given that, number one, it's not children, it's a large challenge that we're all facing. Who should really be getting the vaccine? Well, really, it just should be inclusive of everyone. I mean, I know we know this, but we're not safe until we're all safe. So what are these populations of risk that we need to think about a bit more closely? So it includes, yes, IDPs and refugees and asylum seekers, but also returnees, migrants, irregular or regular status, etc., etc., etc. The list is quite hard, but interesting also, not interesting, but obviously also people who are living in hard to reach areas. We estimate there's about 70 million people who are living in areas that aren't actually under government control. And we've got some great had some great presentations already on some ways of trying to ensure we're challenging that. So it's a 12-point paper, 12 messages within it, and I'm sure this presentation will be shared with you later, so I'm not going to go through this. But the real key thing is that we need to be very intentional as how we reach these groups. So what are their needs? What are their concerns? What are their barriers, whether it's due to political, geographic, or whatever it may be, and how can we combat that? So if we just look at throughout the NDVP, we should be considering what are the best vaccine delivery strategies. How should we be mobilizing them? Should we be using just fixed site? Can we use mobile strategies, outreach? What does the RCC campaign look like for people who are IDPs or who are politically affiliated to a different group other than the government? What are the issues with regards to monitoring or sharing data? Especially around registration that we're seeing. So next slide, please. And you'll see a little map, which essentially shows the graph that we've had before, but I just want you to have a look at the little dots that we have. And yes, lots of the green signifies for the country that campaigns have started, but these dots really show how much vaccine is available in country. And we actually see that a good number of countries, especially in the EMRO and Afro regions, have less than 3%, which is actually what we're hoping for with regards to COVAX for this part of the year, but is still obviously very different to other countries. So I just want to examine this a bit further with the next slide. And if we look at these countries which have humanitarian settings, but are actually have different income status, then we're seeing a huge amount of vaccine inequity. Indeed, the low-income countries, where we have 17 countries which have humanitarian settings, only 2.7 million doses have actually been administered to populations here. Whereas in low middle-income countries or upper middle countries, it's actually quite high. But even if we combine all of that together and we're comparing to the global data that we have, we know that 1.2 billion doses have actually been administered, but only 20 million within low income, within humanitarian settings. And of course, low income settings, low income countries have the least. So next slide, please. So just looking at one huge issue that we're facing right now, which is really around global supply. What we're seeing, if we disaggregate how countries are actually being able to procure their vaccines, low-income countries are heavily dependent on the COVAX facility. And as we know, that's indeed facing challenges due to the supply of AstraZeneca from India and the huge outbreak that's happening there that's having to be controlled. So the supply delays and the current landscape for procuring vaccines is really impacting and will impact low-income countries. High middle-income countries, as we can see, which are countries like Colombia or Venezuela, etc. They're actually able to see, as we're able to see from the green, they're able to procure from other methods. So this is a huge challenge that we're facing. Next slide, please. Some of the general saturated kind of findings that we're seeing, and it is really of no surprise to most of you here, I'm sure, is that we know that there's short expiration dates on a lot of these vaccines, and so we need a really quick rollout. This is actually really difficult in low capacity settings, as I'm sure all of you are aware and work in. But sometimes these campaigns need to be rolled out within 1 to 3 months, which is incredibly challenging to ensure the training and the disbursement of distribution and transport of vaccines across the country. As we've highlighted before, there are supply constraints. There's also insufficient funding actually to reach these hard to reach areas, or indeed just out of the capital areas. And we know that already in some contexts like Ethiopia or Northeast Nigeria, South Sudan or Sudan, they're actually being asked humanitarian partners how they can mobilize funds and indeed support rollout out of the urban areas. We all are very aware about the vaccine hesitancy and preference and safety concerns. And I just want to highlight one interesting example that even in some contexts where we know that routine EPI has been very high, for example, in OPT, occupied Palestinian territories, actually the uptake in those contexts, especially Gaza, northern West Bank, has been surprisingly low. Some other challenges that we're finding, which is not a surprise, is strategies to reach insecure areas or indeed to work with non-state armed groups who may be in control in that area is currently insufficient, whether it's actually the transportation, the logistics, or whether it's the actual coordination amongst them. So we're seeing that incredibly, for example, in Afghanistan, Colombia, Nigeria, Mozambique, et cetera, Somalia. So this is a common theme that we're seeing. And of course, and I think someone wrote this as a question, barriers for populations of concern, especially when registration is electronic, and the fear that that data will be used and shared with authorities, either resulting in detention, incarceration, or indeed attack. And so this is for people living in opposition controlled areas, insecure areas, or indeed for people who may be there without legal status, like irregular migrants. But in general, and this came up in a discussion yesterday, I believe, but the information around how many populations of concern are actually being vaccinated is very scanty right now. There isn't a systematic sort of method of aggregating this data or understanding if equity is really being achieved or not. And so as such, there's obvious concerns for exclusion. But one last thing is the issue around contextual parity. This is something that we're heavily articulated in the position paper, but really populations of concern should be held in equal respect to the wider population. So meaning if there's an old person who's an IDP, they should be entitled and should be able to receive vaccines, much like the wider populations. So next slide, please.
Eva, we will need to wrap up soon. I'm sorry. I know.
Perfect. Last slide then,
Yeah,
which is around the humanitarian buffer. Next slide, which is my last slide, which is the COVAX humanitarian buffer, which has been established. It's yet to go live. It will hopefully do so within the next few weeks. But it's very clear within the humanitarian buffer mechanism, which is a mechanism to procure vaccines, that national plans and governments are, the first mechanism for ensuring you procure vaccines for your high-risk groups, for your populations of concerns. Governments can apply for it, as well as humanitarian agencies, but the gap really needs to be demonstrated as to why it hasn't already been included. Is this a new or an accounted risk that's being addressed here, that has evolved? And humanitarian agencies, if they are to apply, they need to show that there's been a demonstrable gap in coverage and that indeed they have access and trust from the community to be able to roll out vaccines. So yes, and the big final message is that really the buffer is just a measure of last resort, and that the government really have first and foremost responsibility to vaccinate all, regardless of legal status. Over.
Great, thank you very much. You covered a lot of really important information around COVID-19 vaccination in these settings. Thank you very much. We're going to move now to Dr. Nazari, Director of the Afghanistan National EPI Program. Dr. Nazari, we're coming up to the, we have about 25 minutes. I'm going to ask if at all possible, if you could keep your talk perhaps even under 10 minutes so that we have some time for discussion at the end. I apologize about that, but we're going to have to move quickly. Thank you very much.
This is basically looking at the challenges that Afghanistan has seen through with the COVID pandemic, and what efforts have been made to sustain routine immunization services delivery, but also the rollout of COVID vaccine, and just the usual background information. But of significance here is that 13 vaccines are being rolled out by, or rather being implemented by the country. These are the list of the vaccines. Next, please. And just to add that HPV and measles and rubella are also to be introduced soon, so making them 15 vaccines. And just to say that the cold chain system is able to support the delivery of vaccines to about 1.6 million targeted children, and annually about 30 million doses are being delivered. Understandably, some of the vaccines are in 3 doses or so, and that an average of 3 national polio campaigns are being conducted annually and 6 subnational campaigns, leading to the delivery of a lot of doses of polio, 78 million. And the culture system is also largely able to address the needs of the country. About 97% at least of the needs are addressed. And the other, on the left side, is just a distribution of the cold chain equipment that the country has. Next, please. And in terms of the pandemic, that's to say, over 64,000 cases have been reported with almost approaching 3,000 deaths, but most of the cases have recovered, but the pandemic is still ongoing in the country. Next, please. And in terms of the vaccination, so far, the country focused on the national vaccination, or rather national deployment and vaccination plan, and presented that in December. And it's also part of the COVAX facility, and as one of the AMC countries. And the country is requesting about 16 million doses based on the 2-dose schedule to reach 8 million population, which is 20% of the population. The high-risk groups, the health workers, those with comorbidities, and the elderly. Next, please. And procurement is done through UNICEF, focusing on the EAL. So basically, the specifics in the COVAX facility, essence here is that the country is more interested in vaccines that can be kept at between +2 to +8 degrees centigrade. So that excludes some of the vaccines, and focusing mainly on, at the moment, AstraZeneca and other related vaccines that can be kept at that temperature. Next, please. And a number of population groups have been targeted. You'll see that it's a long list, including the ones that are under the initial WHO stage prioritization, but also going much beyond that, and the reasons will be explained later. But basically, all health care workers, and to be reached by routine immunization vaccinators, but also teachers in schools and other public universities, the intention being to keep the schools open, and then security personnel, prisoners, and people with comorbidities, which are part of the initial WHO prioritization. Next, please. And those above the age of 50 years, the nomadic population, all men and women from 30 years and above, and also those living in IDPs because of the high concentration of people, and returnees from neighboring countries because of the anticipated risks, especially those coming back from Iran. And government and private employees working with, who are exposed to likely risks, so to say, and people living in urban slums and big cities. Next, please. So the COVID-19 vaccination was contracted to the basic package of health services, which are implementing NGOs, which are third-party implementers that usually support government in the implementation of routine immunization activities. And but additional vaccinator teams were also engaged in addition to what was the team that has been usually responsible for the delivery of vaccines. And next, please, in terms of the strategies, basically focusing on the fixed facilities, the outreach, and the mobile teams to just make sure that access is taken to as much as possible to the population groups. Next, please. So some of the processes that helped in delivery of the vaccine include issues around advocacy, community engagement, using the media and also risk communication and adverse events following immunization protocol. And especially the last one is really very important because it's a new vaccine that has not been used previously. And monitoring has been found to be really very important to see if there's any untoward or unexpected reactions that can influence not just the COVID-19 vaccine rollout, but also other immunization-related activities. Next, please. Just keep on next until the next here. And vaccination cards were issued. All those that were vaccinated were also registered, and reports were being summarized on a monthly basis. And also the monitoring and evaluation checklists. So basically, this is just to say that there was close monitoring of implementation. Next, please. And almost approaching 1 million doses of the vaccine were received, and that was the Covishield. And more than 500,000 doses have already been delivered. And this is just to express the number of those 73,000 that have been fully vaccinated so far. Received their 2 doses. Next, please. And this is basically the distribution of those that have been vaccinated. Next, please. So some of the challenges that were encountered basically were what was in the news, the issue of the blood clots that were being monitored in Europe, and it really was very challenging and led to hesitancy, especially for the health workers. And this explains why you see the distribution of those that had been vaccinated was beyond the initial focus of health workers, the elderly and those with comorbidities. When the rollout started and the hesitancy came to being, and also the fact that the vaccines have limited shelf life. So eventually it had to be rolled to a larger proportion of the population. And so that was why the expansion, and eventually you'll see how that has evolved. And so the anti-vaccine campaign started with because of that campaign, that report that was coming out from Europe and other places. And this led the Ministry of Health to increase awareness campaigns and opening up vaccination to beyond the high risk group, and launching many vaccination points to just make sure that the vaccines are used. Next, please.
Ahmadou, we'll have to wrap up soon.
So this is probably this. There are other slides, but I think this is probably the important part. Let's go 3. Next, please. Next. So this is just to indicate that initially when the vaccination rollout started, take-up was gaining. Then when the information started coming out in terms of the side effect of the vaccine about blood clot, then the hesitancy aspect really rolled in. And eventually when it was open to the larger population and more centers were created for the use of the vaccine, we saw a steep rise in the utilization of the vaccine. And just to mention that many other countries actually use the same kind of approach, just to make sure that the vaccines are not wasted. So I think we can stop here. Thank you.
Okay, thank you for giving Sudan this opportunity to be part of this important webinar. In these few minutes, I'll be discussing what has been done so far with COVID-19 vaccination in the country, and I will talk about some evidence about COVID-19 vaccine hesitancy and its determinant among healthcare workers in Sudan, and I will conclude with the priority areas for addressing the challenge and what has been done so far to address this challenge. Next, please. Now, since early March, Sudan has received more than 800,000 doses from AstraZeneca Oxford vaccines through COVAX facility. Obviously, there's a limited number of doses. So as part of national deployment plan, Sudan did a prioritization exercise. And with the objective of maintaining health services, healthcare workers have been prioritized to be the first target population group to be fully covered by the vaccine. The second group are those who are above 45 with comorbidity with objective of mortality reduction. Those were initially prioritized groups. However, there have been some raising concerns among healthcare workers regarding their family members who are elderly, but they do not have comorbidity. So at Ministry of Health, we thought this might create some hesitancy among healthcare workers, because healthcare workers may think that, why would I take the vaccine while my beloved family who are elderly are still at risk of dying from COVID-19. So we included a third priority group who are elderly and above 60, healthy, do not have comorbidity, but above 60 years. The maps on the right demonstrate the coverage so far over 13 states out of 18 states in the country. Next, please. Now, up to the 18th of May 2020, 60% of the targeted healthcare workers have been covered by the vaccine. And to have some evidence on COVID-19 vaccine hesitancy among healthcare workers and its determinant, Ministry of Health have done an online survey from March to April, and we had 570 responses. And answering the question, would you take the vaccine? 57% answered yes, and 27 answered maybe, and 14 expressed absolute refusal for the vaccine. Next, please. Now, we did further analysis to check the determinants of the vaccine. This first plot demonstrates these determinants. Each factor tested is represented by horizontal line, and the vertical line represents a line of no difference. So basically, if the factor crosses this line, meaning that this factor does not contribute much into the decision of accepting or not accepting the vaccine. So there have been gender difference in accepting the vaccine. Males were twice and a half more likely to take the vaccine compared to females. And this is really relevant to the context of Sudan, because more than half of health care task force in Sudan are females. And this can be triangulated to what is reported in the literature about adverse events. Adverse events from COVID-19 vaccines, especially AstraZeneca, have been disproportionately reported among females, more commonly among females compared to males. And the other factor is the profession. Nurses were the least to accept the vaccine. And paradoxically, those who rated their knowledge about the vaccine as being excellent were less likely to take the vaccine compared to those who rated themselves as having good or weak knowledge. And this can point out that there is some sort of misinformation about the vaccine among healthcare workers. Next, please. Also, we grouped some common perceptions that might alter the decision to take the vaccine, and like the perceived benefit from the vaccine and the perceived susceptibility to infection, and how serious the perceived seriousness of infection, the severity of the infection, and the perceived safety. Among all these factors, the most important one that had significant impact on acceptability was the perceived harm or the safety of the vaccine. This is really critical because in designing the risk communication messages, if we're going to choose one theme, it would be the focus on safety, because yes, we can do messages that focus on vaccine, it will work, it will prevent you from getting infection, you are a healthcare worker, you are susceptible to infection, you may die from COVID-19, but the most important one would be the focus on the safety. Also, another factor was the mistrusting the manufacturing of the vaccine itself. So this is really critical when for risk communication.
Dr. Kari, are you there? We may have, oh, there you go. You dropped for a moment.
Yeah.
Okay, you're
okay.
back. Good.
Sorry, I lost connection. So taking all these points, the priority areas to address this challenge are we need to have more on the determinants of vaccine hesitancy among the general population. Also, more focus on having adverse events surveillance system for adverse events and response. Now, Ministry of Health has done lots of effort in this part, using the same infrastructure for COVID-19 surveillance, the same hotline, training for at all levels regarding adverse events from vaccine has been done extensively. The other point is the focus of risk communication. Now, Ministry of Health have designed or rechanneled the focus to be to have more detailed risk communication on vaccine safety, more details on the manufacturing of the vaccine, and to build trust for the manufacturing. Now, definitely the presentation is about the challenges regarding vaccine hesitancy, but of course, COVID-19 vaccination in Sudan has been faced by other challenges, like access, for example. So the country is now discussing innovative solutions like mobile clinics to improve access to the vaccination. Thank you.
Thank you very much, Dr. Kari, for that wonderful overview of vaccine hesitancy in the Sudan. And I think, a lot of the lessons you've learned are relevant to many other countries. And I also appreciate your brief presentation and staying on time. Thank you very much. So we're going to conclude this webinar I'm going to hand this over to Dr. Robin Nandi of UNICEF, who's going to conclude the session with the discussion and overview. And I just personally want to thank all of our speakers for the fantastic presentations that they've given. We've covered an enormous amount of ground, both high level and then very detailed studies from particular countries. So Robin, over to you to conclude the webinar.
Yeah, thanks, Bill. And thanks for chairing. And I want to really reiterate your thanks to the to everybody who presented. I mean, this was really rich a set of presentations that covered a lot of ground, from challenges and successes in delivering vaccinations to humanitarian fragile conflict settings, challenges and supply side barriers, demand side barriers, and really also putting into context the at-hand challenge of delivering COVID-19 vaccines as well in these settings. But I just want to reflect, and having listened to all these presentations and Kate's opening remarks, at the beginning. Just to say that I think everybody has come around to the fact that progress in immunizations, whether it's IA2030 or Gavi 5.0 goals, cannot be achieved without successful service delivery, sustainable service delivery in conflict-affected and fragile populations. I do believe that IA 2030, sets us up very nicely and really highlights this importance and the focus on zero dose, the critical shift between the focus on zero dose children to a focus on zero dose communities. That is, the communities where large numbers of zero dose children are clustered in would drive us to a kind of prioritization which will hopefully set us on the path to progress in some of these populations. I also want to say that when we talk about the focus on zero dose communities, one of the shifts that we are seeking, and I say this also to reassure our non-immunization participants in this group from the wider emergency and humanitarian population community, is that we are not seeking to push immunization vertically as perhaps we have done in the past. We see immunization as an entry point to more comprehensive primary health care for these populations. The second thing on this is even the zero dose is not, the aim is not to convert a zero dose to one dose. And I think I want to be really explicit here And we need to sustain our focus in these communities until these children go through the series of vaccinations towards fully immunized fully immunized child, and even beyond to comprehensive primary healthcare services. So I just want to put it out there. COVID-19 pandemic is also, of course, challenged us in many ways. We will see declines in coverage. We have seen declines in coverage in many fragile and humanitarian contexts due to the disruptions that were, either due to shifting priorities, addressing COVID-19, or transport disruptions, lockdowns, and so on. So we will see a backsliding in many of these situations that we will need to catch up on. But I also want to us to be forward-looking and predict problems. As more and more COVID-19 vaccines become available, most of the countries that are experiencing humanitarian emergencies, fragility, do not have an adult vaccination program to build up on. So they will use the resources of childhood immunization and routine immunization to deliver COVID-19 vaccines. So we need to be proactive and mitigate any future disruptions as we deliver. And then also the principle of more comprehensive services. We do not want to reach humanitarian populations with single antigen COVID-19 vaccines when these communities have multiple deprivations. So how do we integrate it with a more broader? And even as we recover from COVID-19 disruptions, I mean, there were questions in the chat on polio and measles and so on. We cannot catch up on immunity gaps antigen by antigen. We just won't have the funding to do that. We need to make sure that we ensure efficiencies and bring our communities together, immunization and emergency. So this is about partnerships. And I think that's really critical, that we really reaffirm the partnership between the immunization and humanitarian. And then my final point is that IA2030 belongs to all of us. It's not a WHO document. It's not a UNICEF, not an IFRC document, not a Gavi document. It belongs to all of us, not only the immunization, but also the broader humanitarian communities. And please do look at linkages between the different strategic priorities. I do not want to see SP5 as operating alone or going it alone. There are huge synergies and alignments that need to be sought with others. There were questions on vaccine costs, innovations. These are all covered in IA2030. Thank you, Bill.
Thank you very much, Robin. That was a wonderful summary and closing of our webinar. So we will officially close the webinar. Again, I want to thank all of our speakers and Robin for your closing remarks. I want to give thank the IA2030 SP5 working group led by Frank Mahoney and Ahmadou Yakubu. I want to thank the organizations behind this, the International Federation of Red Cross and Red Crescent Societies, UNICEF, WHO, my colleagues at IVAC for hosting this, and Andrew Lan for organizing this, and all of our translators. So thank you to all of you, and I hope you found this a rich and rewarding webinar.